Can you start the presentation, ma'am?
Yes, sir.
Okay, please proceed. Over to Dr. Vidya.
Yes, sir. So my topic is 65-year-old male, known case of essential hypertension for 15 years duration on telmisartan 40 mg, silacar 10 mg, posted for open bilateral inguinal hernia repair, sir. So first of all, hypertension is when the blood pressure is more than systole more than 130 and diastole more than 80 millimeters of mercury. And since this patient is come with the complaints of bilateral inguinal hernia, I start with the presenting complaints. Whether the patient has swelling in the bilateral groin, I will ask about the size, location, onset, progression, whether it is associated with pain, the swelling increases on straining or coughing, whether it is reduces on lying down, is there any discoloration, any discharge, whether the patient has swelling elsewhere in the body, and eliciting the causes for inguinal hernia. The patient could have any history of chronic cough, any history of straining during urination or defecation, and is there any history of chills, evening rise of temperature, and loss of weight and appetite. And other symptoms pertaining to long-standing hypertension, whether the patient has any history of chest pain or palpitation to rule out angina, patient has any breathlessness, swelling of legs to rule out heart failure, and is there any weakness of face or limbs to rule out cardiovascular disorders, cerebrovascular disorders, and whether the patient has urine output or not, whether the patient has a known case of CKD, is there any blurring of vision? Then in the past medical history, how was the patient diagnosed with hypertension, whether on routine health checkup or patient had any complications because of hypertension, and what was the initial BP? Was he advised on medication immediately or was he on lifestyle modification? Whether they started him on any one drug, then there was any modification of doses or addition of any drugs? Was there any need for emergency admissions like a pulmonary edema or any end organ damage? Whether he is on any anticoagulants or antiplatelets? Other than this, past surgical history, personal history like history of smoking, alcohol, drug abuse, any history of bowel and bladder disturbances, and finally history pertaining to the functional capacity of the patient to rule out the metabolic equivalence. When it comes to general examination, since it is an elderly patient with 65-year-old, we have to assess the mental status. We have to look for the build of the patient. Have to look for pararectus cyanosis, clubbing. Since it is a swelling in the inguinal area, we have to examine whether it is a lymph node or any other lymph nodes present elsewhere. There is pedal edema present or not. Vitals measurement, BP should be measured in sitting position. If the patient has history of diabetes, we have to measure it in the sitting and the standing position. We have to look for pulse, whether it is regular in rate, rhythm, normal in character, whether the patient has any arrhythmias. We have to measure the baseline vitals. Then we have to look for any raised JVP suggesting heart failure. And then airway examination. Since he is an elderly patient, we have to look for the neck movement, jaw protrudement, mouth opening, malymphatic grading, and thyromental and sternomental distance. On systemic examination, cardiovascular and respiratory, to look for any abnormal sounds or abnormal murmurs. And abdominal examination and the local examination, we have to do inspection and palpation of the inguinal hernia to look for size, extent, and whether the size increases on cough impulse, whether it is reducible or not, whether the content is a bowel or something, and we have to confirm the inspector findings by palpation. Then along with routine investigations, we have to do investigation to check for the end organ damage like renal function test, serum electrolyte, liver function test, chest x-ray, ECG and echo. In chest x-ray, there is any signs of pulmonary edema or fluid overload. In ECG, we have to look for any abnormal rhythm, any conduction abnormalities. Is there any left ventricle hypertrophy or signs of myocardial infarction? In echo, we have to look for any signs of myocardial infarction. Is there any ventricular systolic or diastolic dysfunction, any valvular abnormalities? Is there any signs of heart failure? Whether the patient has any ectopics or abnormal rhythm. And since it is a low risk surgery and low risk for major adverse cardiac events, no further cardiac testing is required for this patient. Considerations: in untreated severe hypertension, it can lead to perioperative morbidity like myocardial ischemia, arrhythmia, cerebrovascular accident, renal failure, pulmonary edema, and excessive surgical bleeding. And side effects because of antihypertensive drugs like ACE and ARBs will lead to refractory hypotension. Patient on long-term beta blockers, it will prevent the physiological changes like tachycardia in response to pain, awareness, anaphylaxis, and malignant hypertension, which make us difficult to diagnose the adverse events, and excessive bradycardia. Renal function should be monitored in patients who takes ACE inhibitors. NSAID should be used in caution with the patients using ACE inhibitors. Use of diuretics will lead to fluid and electrolyte disturbances, and there will be greater swings of BP during induction, extubation, laryngoscopy in a hypertensive patient, and autoregulation will be shifted to right in a chronic hypertensive patients. Antihypertensive drugs and anesthesia interaction. Both anesthetic agents and antihypertensives will lead to cumulative hypotension. Induction will lead to hypotension. Laryngoscopy, pain, extubation responses will lead to hypertension. Drugs like propofol, thiopentone will lead to hypotension. Ketamine will lead to hypertension because of stimulatory properties. So our goal is to maintain a normal or a slightly higher blood pressure for a hypertensive patient than normal patient. We should avoid swings in blood pressure during perioperative period. Preoperative optimization, a routine NPO, ACE, ARB should be stopped, like telmisartan should be stopped 24 hours prior to surgery. Diuretics should be, the patient should be evaluated for any fluid overload or electrolyte abnormalities. We should avoid diuretics, or if the patient is on failure, we have to continue the diuretics. And anti-anxiety drug like diazepam or midazolam, the night prior surgery or 2 hours before surgery. Since he's an elderly patient who has high risk for aspiration, anti-aspiration prophylaxis like proton pump inhibitor and H2 blockers. Patient can be taken up for surgery if the BP is less than 180 systole and less than 110 diastole. And it is a below umbilical surgery and a patient with elderly patient. So I would prefer the plan of anesthesia as combined spinal epidural anesthesia, sir. So patient should be adequately filled before giving regional anesthesia. Standard ASA monitors including non-invasive blood pressure, ECG, pulse oximeter. If the patient is a high-risk patient and if the surgery is a major surgery, I would go for intra-arterial BP. For this patient, non-invasive blood pressure monitoring is enough, sir. Then maintenance. In case if the patient is giving a refusal for regional anesthesia, if the patient is on any anticoagulant, then we can go for general anesthesia with TAB block or ilioinguinal and iliohypogastric block or local infiltration. So pre-oxygenation, and we should do a smooth, gentle, and fast laryngoscopy and intubation. Induction drug of choice would be etomidate, which is cardiostable. We can give thiopentine and propofol, but as a titrated doses. Laryngoscopy response should be avoided by giving short-acting opioids or short-acting beta blockers or IV lignocaine 1.5 mg per kg IV. Maintenance, we have to maintain adequate depth, adequate analgesia. We have to avoid hypothermia, hypercarbia. The patient should be adequately filled and vasopressor should be ready and started if appropriate. Recovery. During recovery, monitoring should include ECG, BP, pulse oximeter. Coughing should be avoided during recovery. Patient may develop hypertension because of pain, a distended bladder, and anxiety. So we have to rule out all the reversible causes during recovery and in the post-op period. Only then we have to consider antihypertensive drugs. Supplemental oxygen to prevent hypoxia, and we have to prevent all the hypertensive triggers in the post-operative period. So we have to treat pain, hypoxia, and also any hypertensive triggers in the post-operative periods. That is also
very good. So fairly detailed presentation, but needs a little bit of modification here and there to make it. First of all, what you should understand is these sort of case scenarios are actual virtual patients when they are given in the examination. Your aim must be to focus on the case given with the nature of the patient, the drugs they are using and their effects, and the plan for your anesthesia. So you need not generalize your presentation saying that in case he has this, I will do that. That is not required. So what you have to concentrate on, for example, this patient, I have given the scenario, the patient is on telmisartan and silacar. You have not mentioned anything about the silacar and what is its interaction in this patient.
yes,
and telmisartan is an ARB.
yes,
So
sir.
ARB and ACE producers, but why ARBs are becoming more popular than ACEs nowadays?
Sir, they do not cause the side effect like cough, which is produced by ACE inhibitors.
And also, so some patients develop acute angioneuritic edema. It produces some sort of angioneuritic edema in some patients when it is initially started. So all the risk is avoided. But the common feature of both ACE and ARB is they can cause irreversible or refractory hypotension, especially after a regional technique, and better to withhold them at least for 24 hours. Okay, so that advice in the pre-op preparation, you should have mentioned exactly how many hours before you have to stop that. And by stopping this drug, if the BP goes up, what you are going to do to manage that, what drug you are going to give, and what is the interaction, what is silacar? It's a calcium channel blocker. It's an advanced generation or a newer generation of, the oldest one is nifedipine. Then came amlodipine. Now this is cilindipine. So like that, the newer generations are coming. What is the advantage of this cilindipine over amlodipine and nifedipine? Most of the
Nifedipine causes
cardiologists.
profound hypotension. Sir.
Huh?
Nifedipine causes profound hypotension.
Not profound hypotension unless it is by which route it causes profound hypotension.
By vasodilation.
Sublingual.
No. Intranasal or sublingual. Okay. In those days, it was used for control of sudden bouts of hypertension by intranasal filling of the gelatinous capsule, which contains liquid nifedipine inside that. That can be they used to spit it inside the nasal mucosa or put it sublingually. But that practice has now been condemned and it is not to be done for control of blood pressure. And nifedipine used to produce reflex tachycardia because it produces mainly, what is the mode of action of calcium channel blockers?
Vasodilatation.
Smooth muscle relaxation in the vessels. That is
Yes,
the
sir.
mode of action. So it causes vasodilatation by smooth muscle relaxation in the vascular compartment. And so they used to produce orthostatic hypotension as well as tachycardia. And amlodipine had one peculiar problem. It used to produce ankle edema, which is mistaken as a failure edema, but it is enough that once you stop the drug, it used to vanish. So this cilindipine has now been proved to be much superior to both these first and second generation of calcium channel blockers. And calcium channel blockers at times can also increase the chances of heart block or conduction defects because they interfere with the cardiac activity also, because calcium is an important element, as you all know, in the pacemaker cell activity. So sometimes that also can interfere. So like that, you must try to concentrate first on your given case scenario and try to present it coherently in that way. And then if the examiner asks what if the patient has this problem, that problem, then you can elaborate on that. Now, coming from the very first line of your presentation, you described that a patient having a BP of more than 130/80 is considered a hypertensive.
Yes, sir.
Is that a very simple definition like that to make call a patient as hypertensive?
So more than 130/80 in 2 or more occasions.
Which position, sitting or standing?
In sitting positions.
Some books say it is sitting, some books say it is preferable to do it in the standing position because we go to the recumbent or sitting position only for lesser number of years hours compared to standing in our day-to-day life. So they say always a standing BP of less than 130/80 is considered as the ideal BP for any age group. Who defines this limits of BP? Which is the medical group or the association which decides what is the ideal BP for the public or the population? There are two groups. One is called Joint National Commission on Hypertension, JNC, Joint National Commission on Hypertension.
Yes,
They
sir.
are the ones who periodically review the comorbidity of hypertension in common people and try to advocate the drug therapy also based on the developments that are taking place in the pharmaceutical industry. Okay.
Yes, sir.
So JNC in the earlier, so every year you have a JNC commission report coming up. That is called first commission, second commission, third commission. Now the latest commission is about 9th Joint National Commission on Hypertension. And earlier, what was the drug regime that was recommended for treatment of hypertension? Which was
Sir,
the first line of drug?
if the patient is less than 55 years, then the drug of choice is ACE or ARB inhibitors.
That is the current one. But earlier it was beta blockers. Okay?
Yes, sir.
So earlier, younger the age group, beta blocker like metoprolol or propranolol. So whether it is cardioselective or non-cardioselective, that was the recommendation given up to 7th Joint National Commission on Hypertension. Later on, they devised that because cardiovascular, they withdrew the recommendation of beta blocker in preference to ACE or ARBs.
Sir, preoperative initiation of beta blockers will lead to stroke and.
No, I am talking about Joint National Commission is not worried about operative or preoperative. These recommendations are for the general public who suffer from hypertension. All of them need not come for surgery. Okay, this is a general recommendation for treatment of the comorbidity of hypertension in the general population. So earlier, as I told you, up to 7th Joint National Commission, they were recommending beta blocker as the first line therapy. And that is up to, as you said, up to 50 years, beta blocker was the first line therapy. Maybe you can add, if it is not coming under control with beta blocker alone, you can go for a diuretic along with that. Anybody above 50, they recommended calcium channel blocker like nifedipine or amlodipine. But this concept was changed recently in the 8th and 9th Joint Commission report, that the first line of drug should be ACE, then they changed that to ARB also. So the current recommendation is anybody below 45 or 50, the recommendation is you will treat them with ARBs, and anybody above 50, you go for calcium channel blocker. That is the way they now recommend the treatment. So to follow that, you have to say that patient should have a BP. Earlier also, if you remember, 140/90 was the limit. Systolic was 140, diastolic was 90. But now, irrespective of the age, they have said everybody should have only 130/80. Earlier it was 120/80, but lot of protests came from the practitioners saying that elderly people, you cannot expect them to have 120/80. So now they have raised the systolic to 130, and now the recommendation is 130/80, preferably in the standing posture, at least on 2 or 3 occasions. If it is consistently high, why they wanted to take 2 or 3 readings?
It could be because of anxiety.
Rule out white coat hypertension.
White coat
That is the answer you have to give in the exam. Okay, why they have to take the BP at least on 2 or 3 occasions is to rule out white coat hypertension. That is the simple answer that you have to give. So once that is confirmed, what is the initial recommendation for treatment? Do you immediately prescribe, for example, on the 2 occasions or 3 occasions you take, the patient's blood pressure is 140/90 instead of 130/80. Will you immediately recommend medications, or would you
Lifestyle
like to?
modification.
What are the lifestyle modifications that can be advised?
Sir, salt restriction.
Very good. So how does salt restriction help? Because you normally require salt for your day-to-day activity.
Yes,
If you don't have adequate sodium in your body, what can happen?
It increases the intravascular volumes
So,
because of
Cerebral edema.
cerebral edema.
it increases the tonicity. So
What is the common complaint patient will have if they don't take adequate salt? Especially if they are
Giddiness.
manual workers.
Headache.
Cramps, muscle cramps will happen. Okay? That is the most common feeling that patients will exhibit. Okay? So, but salt restriction, what is the maximum salt that can be taken to avoid medications to control hypertension?
less than 5 grams per day.
3 grams. Maximum recommended is only 3 grams. Okay? So 3 grams of sodium chloride is allowed. And if you take more than that, it is supposed to cause, maybe the causative factor for hypertension. So that is the first line of treatment that you do. Then what is the next lifestyle modification you can advocate?
Daily activities like
Physical activity.
Physical
So
activity.
instead of being sedentary, you should do at least some minimal basic exercises, do some physical activity, right? Number 2. Number 3.
Quit smoking, sir.
Stop smoking.
Smoking. If you are a
Smoking and
smoker,
alcohol.
alcoholic, you can stop all that. Very good. Then, is there any psychological reasons for hypertension?
Stress.
Stress. So stress you should avoid. How can you avoid the stress?
Adequate sleep.
Depends on
Yoga, no medications. Try to avoid any pharmacological agents as far as possible in lifestyle modification.
yes, sir.
So whatever things that can be modified by changing your day-to-day routine, that is what is called lifestyle modification. So the 4 modifications you can advise a patient is reduce your salt to less than 3 grams per day, do physical activity routinely at least for 20 to 25 minutes, quit smoking and alcohol if you are addicted to that, or even if you are a social drinker, try to restrict it to the minimum possible. And 4, try to reduce your stress by yoga, meditation, and all these things. Okay, so these are called the lifestyle modifications. Sometimes the examiner may ask you that if your patient comes to you for pre-anesthetic assessment, because surgeons won't talk about hypertension and all these things, and he wants the advice from you, you should be in a position to advise them, because if surgery is planned, say 1 month or 1.5 months later, the patient can get his BP controlled by this sort of lifestyle modifications if the blood pressure is not alarmingly high. Otherwise, if after 1 month of trial of these things, if the blood pressure is not coming under control, then they can start on these drugs which are recommended, like a small dose of telmisartan for people less than 45, and a calcium channel blocker, preferably as cilindipine as start medication for above 45 people. Right, that is the first thing. The second point you said about, I will take the BP in lying, sitting and standing posture if the patient is a diabetic also. Does not a patient without diabetes require an examination in the both sitting and standing posture?
Yes, sir.
Then what is the reason for checking the BP in both the postures?
Rule out orthostatic hypotension.
Orthostatic hypotension. So it is not always necessary, only a diabetic patient with autonomic neuropathy should have orthostatic hypotension. Even an hypertensive patient in the early stages of his treatment with medications can develop orthostatic hypotension. So don't specifically say that if he is a diabetic, I will do it, otherwise it sounds as though you won't do it in a regular non-diabetic hypertension. So all patients with hypertension, whether they are diabetic or not, you have to take the blood pressure both, preferably in the lying, not even in the sitting, lying and standing posture. That only will correctly reflect whether the patient is having a chance of orthostatic hypotension. So how will you know that there is orthostatic hypotension? What are the values to indicate that there is orthostatic hypotension?
So if the systolic BP drops more than 20 millimeters of mercury from sitting to standing.
Yes. Okay, very good. So that is the correct method of checking the orthostatic hypotension. And then as you progressed in your presentation, another point that I wanted to clarify is BP drugs. In the preoperative presentation, in the history taking, you mentioned all about how the blood pressure was diagnosed, how his drug was started, whether he was advised lifestyle modification. I think all that you have picked up from my earlier notes and then mentioned that. And in that situation, you said, was there any need for admission in the hospital due to pulmonary edema? Is that the only common reason for a patient to get admitted? Any common hypertensive patients? What is the more common emergency that a hypertensive patient can get admitted in the hospital?
Cerebrovascular accident.
Cerebrovascular accident.
Hypertensive emergency.
Yeah, what are those hypertensive emergencies? What are the names for that? Accelerated hypertension. Have you heard of that word? And
Yes,
malignant hypertension. Okay, these are two common hypertensive emergency crises that can happen in a patient. more than pulmonary edema or cerebrovascular accidents. They all come under a very serious complication of hypertension. And these two conditions, sudden rapid rise in the blood pressure on a patient who has been on regular medication, it is called accelerated hypertension. Okay, sudden abnormal elevated blood pressures in a patient who has been on regular medication to control the blood pressure is called accelerated hypertension, and the values may be as high as 220 systolic and 120 or more of diastolic. When will you call it as a malignant hypertension?
If the patient has end organ damage.
End organ damage. What is the common end organ damage that you can easily pick up in the clinical setting itself?
Vision loss, sir.
Optic
Papilla
nerve
edema. Papilla edema. Okay, by doing a fundoscopy, which is the simplest method of identifying a target organ dysfunction, is papilla edema. And if papilla edema is present, it is called malignant hypertension. If papilla edema is not there, but only a blood pressure which is abnormally high, then it is called accelerated hypertension. So if you diagnose accelerated hypertension in a patient, how do you manage them? Suppose you want to become an intensivist and a known hypertensive patient who has been having a BP of normally say 140/90, 140/100, suddenly lands up with severe headache, visual disturbance, and comes with a BP of 220/130. You are the intensive care physician. What will you do?
So we'll confirm the BP reading. We'll ask the history and review the medications the patient is on, and rule out any end organ damage. Then I'll try to.
What is the first answer you should say in the exam for this question?
Yes, sir.
What is the first answer you have to give in the exam if this question is asked? If you are in the intensive care unit and the BP of patient with a BP of 220/140 is brought, what is your first thing that you will do?
If there is no end organ damage, we can control the.
Admit the patient. That is, the patient should not be treated as an outpatient. Okay. Any accelerated hypertension or malignant hypertension requires inpatient admission. Patient should be admitted in a high dependency unit and observed. After even 15-20 minutes of observation, if the blood pressure continues to be high, then you have to start drugs to reduce the BP. Like what are the common drugs that you can use to reduce the BP? Oral or parenteral?
If it is an emergency and if it is very high, we can start with parenteral intravenous antihypertensive agents.
Nitroglycerin. Okay, you can start on patients with intravenous nitroglycerin. And how do you reduce the BP? Can you bring it down from 220, 140 to 140, 100 within 5-10 minutes by increasing giving a large dose of nitroglycerin?
No, sir.
So what is the recommended rate? Because these are all given in the emergency medicine books. How to control, how to reduce the BP, what percentage of the blood pressure should be reduced every hour, and what is the reason for that controlled reduction in blood pressure instead of a drastic reduction. All these things are given in medical books.
20%.
20% per hour is the reduction that you should achieve, because if you do it drastically, as you rightly said, autoregulation in these patients are shifted to the right. So cerebral perfusion will suffer badly and patient may develop a stroke when you reduce it drastically from 220, 140 to 140, 100 within a matter of half an hour or 1 hour. So this is the two emergencies that you have to remember. And so that is a more common reason for the patient getting admitted, and which history you have to elicit. And then coming later on to the optimization, you have to advise them that you have to stop the telmisartan 24 hours prior, and if necessary, if the BP goes up. And the monitoring of blood pressure control, that is another important history that you should take. So how does the patient know whether the BP is under control or not? Does he go to the physician every time to get his BP checked, or any nurse is coming and checking his BP? Or nowadays patients have your Omron BP monitors are available. Even the public know that how to use it. Very simple methods have come, and quite intelligent and affordable patients, they buy this machine and they can check their blood pressure. What is BD-BP chart? Have you heard of that?
Yes, sir.
B-
BP measurement twice a day.
Twice a day, morning and night. Why that is recommended? What is it a substitute for? What is the ideal method of monitoring a patient's blood pressure?
Sir, at home,
Hmm.
you should, under his normal working circumstances.
Okay. What is that called? At home?
Ambulatory.
Ambulatory Holter monitoring or ambulatory blood pressure monitoring. Okay, if you want to know whether the patient's blood pressure is behaving normally or not, the most ideal technique is to put the patient on Holter ambulatory blood pressure monitoring. Have you ever seen how it is done?
Yes, sir.
How is it done? Who is saying yes, sir?
Soundarya, sir.
Soundarya. How is it done?
Holter's monitoring in hospital, I have seen, sir.
Oh, ambulatory means you send the patient home. So patient will have the BP cuff all the 24 hours. So he will be asked to come to the hospital. They will tie a BP cuff, which will be automatically inflated telemetrically by using a powered battery system will be there. He has to wear it like a belt along with that. And they will set the reading of measuring the blood pressure every 1 hour time. Okay, so automatically the cuff will inflate and the pressures recorded, and that will get recorded in the base unit in the hospital. So after 24 hours, they will give you a report where there will be a blood pressure measurement taken every 1 hour, and especially during the night when sleeping hours, even that time it will be measuring. So early morning surges, if they are present, that is between 2 a.m. to 5 a.m. if it is present, if the blood pressure according to the circadian rhythm, when patients are supposed to have a sound sleep, if the blood pressure surges at that time, that is an indicator that the blood pressure is not at all under control. The medications need to be reviewed, and we have to increase or find out the cause why this surge occurs even during a deep sleep hours. Okay, so that is the reason why you do the what is called the Holter monitoring, and so this BD-BP chart is supposed to be a fairly equal substitute for Holter monitoring, because all the patients cannot have the Holter monitoring, that is a little expensive. So instead of that, if a patient has his blood pressure checked both in the morning and in the night, one, it removes the element of white coat hypertension, and second, it measures the patient's blood pressure under different settings. So mornings he may be fresh after a good sleep. After work in the night, he may be having a little bit of tension and tiredness. So how the blood pressure behaves during these two occasions will give you a fairly good idea about his blood pressure control. Okay, so that is one of the things that you have to remember. That may be asked sometimes, how to do the ideal method of monitoring and frequency of monitoring, how the patient, and even Joint National Commission for Hypertension has said that depending upon the patient's age, what is the interval at which they have to get their BP checked? That also that recommendation has been given. If you read that report, it's very wonderful to get all the knowledge for that. So if a young patient, less than say 25, 30 to 40, If he is an hypertensive and after starting his medications, if blood pressures are under good control, it is enough if he takes his blood pressure once in 6 months. And as age increases, the frequency will become more. So instead of 6 months, it will become 3 months. From 3 months, it will become 1 month. From 1 month, it will become 15 days. And from 15 days, it will come to 7 days, depending upon the patient's age and the severity and their response to medication. So even that has been thought of, and this has to also to be inquired, because this patient is a geriatric patient, 65 years, and he has been suffering from the hypertension for the last 15 years. So how much of follow-up he is doing with the treatment, that is also very, very important. Right. So with all these things, now you go to the surgical problem. And in the surgical problem, you need not elaborate it so much like a surgery case presentation, like a final year student presenting bilateral inguinal hernia case given to them. Your main aim is to see how much is the bulge and how long the surgery may take, because your anesthesia is going to be planned based on the surgical difficulty and the surgeon's ability. These two things only will decide. For example, if he is a marathon surgeon who will do bilateral herniorrhaphy for 4.5 hours, it is very difficult to manage a patient under regional technique with this. So you have better plan for a general anesthesia straight away and you decide so that you can make the patient as well as the surgeon comfortable. Okay. So for that reason, if the bulge is small, it is like a bubonocele, or if it is a small bulge with a small momentum only coming, no bowel, nothing, then it can be easily managed. Maximum say 1 hour for one side and another 1 hour for the other side. At the most 2 hours, you can finish it off. In that case, it is easy to manage the patient and the regional technique itself. And if you are, as you rightly said, if the patient refuses regional and he wants only GA, you have not mentioned one more thing about that care. You mentioned about the different induction agents, but you have not mentioned about the airway security. Your presentation shows that you always want to intubate the patient, because you said I will avoid the hypertensive response by laryngoscopy and intubation. Can't this be managed with a supraglottic airway device?
Yes,
That
sir.
is another good option you have to remember in the examination.
Okay,
So
sir.
all patients who are likely to have a shoot up of BP because of laryngoscopy and intubation, and if the surgery is a superficial procedure, it can be as well managed with a second generation or third generation laryngeal mask airway. This being an elective surgery, patient will be adequately starved and there is no risk of regurgitation and aspiration. So a supraglottic airway device will be a better choice than going in for laryngoscopy and extubation. And of course, the intraoperative pain management and postoperative pain management should always, you should use the terminology, I will go for multimodal anesthesia technique. Okay. So that these are some of the terms that are expected from you in the exam. So you have to just remember those terminologies and use that. And your preference for combined spinal epidural, that also you have to explain why you want to go for a combined spinal. Why not go for a straight subarachnoid block with a long acting agent like bupivacaine heavy, or why not go for a simple epidural itself with a catheter or a single shot? All those options you have to answer if they are asked. So what is the reason for your preferring the combined spinal epidural as a regional technique?
Sir, it is a bilateral open surgery. So intra also it will take longer duration and it will also provide post-op analgesia.
Okay. Any other reason?
It avoids the side effects of general anesthesia.
No, between combined spinal epidural and straightaway epidural, what is the advantage of combined spinal? Which will produce a better muscular relaxation?
Spinal gives better.
Subarachnoid, because you are giving an element of subarachnoid block also.
Yes, sir.
but with a smaller volume. Okay, what is the level of block required for bilateral hernia surgery?
Up to T10s.
T10. You require T10 for that?
T6, sir.
Oh, that's too high. Why T6? It's not cesarean. It's a hernia. Okay. You said iliohypogastric ilioinguinal.
Sir.
What is the nerve root of that?
T12L1.
T12L1. Okay, so T12 is more than enough. T10 is not required. So it's a very low block that is required. And the T12L1 are the main nerves that supply the area of the skin that is perceived in the inguinal region. So giving a very small volume by the combined spinal epidural technique will produce a very good relaxation of the lower abdominal muscles for the surgeons to do a good repair. And it will be, as rightly someone said, it's a quick onset and surgery can be started. And with the catheter, the time duration is not a constraint. You can prolong the analgesia for any number of hours required, and including the post-operative period also. Okay, so these are all the justification. And of course, you can avoid the hassle of GA. And GA also always has the possibility of what is called an alpine anesthesia. What is alpine anesthesia? That is the terminology that all of you should know with regard to patient coming for hypertension coming for surgery, especially under general anesthesia.
During induction, the BP suddenly goes high and suddenly drops.
So alpine is nothing but a description like the Alps mountains, where they go for skiing as a sport. No, you would have seen, all of you would have seen in the YouTube or pictures, where patients, the people who pursue the sport of skiing will start from a very high level, slide down, and then again climb another mountain, another slide down. So it will be ups and downs. So that is the description of the alpine mountains, the mounts in the Alps. Like that, if your blood pressure chart shows a sudden shoot up, then a decrease, then a shoot up and a decrease, that is called alpine anesthesia. This will cause severe problem with the autoregulation in the brain, and that may cause a delayed recovery. Patient may have some amount of cerebral edema, and that may be the reason for the delayed recovery after general anesthesia. So it is better to have a very steady state of blood pressure rather than the alpine technique of anesthesia, which can be avoided by giving a combined spinal epidural. And you said bilateral inguinal hernia block. So that is another question that can be asked in the examination. How to give a hernia block, and is it advisable to go for bilateral inguinal hernia cases for a block on both sides? Or
Sir,
what are the
bilateral
criteria
block,
to choose? Pardon?
bilateral block can produce a sensation of numbness over genital area. Patient might feel uncomfortable like during ambulation.
Bilateral, is that the reason for avoiding bilateral?
The ilioinguinal nerve, what we block, usually supplies
Does the ilioinguinal supply the genital area? Supplies mostly
the
the
medial.
inguinal area.
Okay.
It is the genital branch of genitofemoral nerve. That is the one which is supplying the inguinal, the genital area.
Genital area.
Okay?
Yes.
Ilioinguinal does not go up to the genitals. It stops short at the pubic tubercle level, from the anterior superior iliac crest to the pubic tubercle, which is the line, imaginary line joining the inguinal area. That is where the ilioinguinal stops. Okay. So
Yes,
it's a genital branch of genitofemoral which is piercing from the middle of the inguinal canal and coming down and supplying the genital area. Okay.
Yes, sir.
But the main reason why bilateral hernia should not be done under block is the volume of local anesthetic that you require to block if you do both sides will be almost encroaching on the toxic level. You may go in for local anesthetic, systemic toxicity, or what is called last. So you require minimum 30 to 40 ml to block one side itself. Whereas if you do on both sides, you will be using almost 60 to 80 ml. Okay, that may produce a very high concentration, and that may be absorbed and produce systemic local anesthetic toxicity. That is the reason why you are not supposed to give bilateral block at the say in a patient when he undergoes bilateral surgery. On the contrary, you can selectively under ultrasound guidance go for ilioinguinal block at the landmark above the anterior superior iliac crest, where they pierce and come out and try to supply the inguinal region. So USG guided US guided bilateral ilioinguinal block can be given as a main method of supplementary analgesia, rather than talking about bilateral hernia block. That should not be performed. That is one thing that you have to remember. Okay, and sometimes they may ask you, have you ever seen a hernia block, how it is done? So for those, in case the examiners are very interested in that, actually you have to do the injections at 3 levels. One is to block the ilioinguinal valve at the above the superior anterior superior iliac spine. One finger breadth medial to that, you have to pierce the skin, subcutaneous tissue, external oblique, internal oblique, and this nerve lies between the internal and the transversalis fascia. So that is the location where you have to deposit about 5 to 10 ml to block this nerve. Then the second injection should be in the middle of the inguinal canal, where the genital branch of genitofemoral nerve comes. So there you have to inject about 5 to 10 ml. And the third injection should be subcutaneously from the pubic tubercle towards the umbilicus in the midline to block crossover fibers coming from the opposite side. Okay, so this is how we used to do the hernia block, and it is a lovely technique for very thin patients with a very small hernia, and elderly patients. It can be done very nicely without any other complications. Okay, so these are all the points that I wanted to discuss from your presentation. So I'll just now go to give you a gist of